Good morning, everyone, and a special thanks to Professor Simons for allowing me to tell you our experience. So I work in Lisbon, and during almost 20 years I've been connected with the implementation of the newborn hearing screening in Portugal, although in an informal way. So, like in most countries, we performed high-risk screening, not universally throughout the country, especially in cities, large cities. And in 2002, we started small experimental programs that tried to be universal. All the programs were hospital-based, and the teams and the children themselves were invited, so it always worked on a voluntary basis. And the screening programs were organized concerning the indications of the Joint Committee of Hearing Screening of America, for the year 2000. Then voluntarily again, a group of professionals tried to implement and to create some rules. So this is the initial steering group, and this steering group was composed of mostly ENT physicians, audiologists, pediatricians, and nurses. So, what we tried to do was to write recommendations, adapted recommendations for the Portuguese reality that could be acceptable and implemented. And we wrote recommendations that were endorsed by the scientific societies, namely the ENT Society, Pediatric and the Audiological Society. Then we started training the screeners and the people who would be in charge organizing local programs. And we also had to find funding to buy the equipment, because the national health system were not interested in funding us, so we had to find funding elsewhere. And lots of corporate companies gave us money, and we were able to provide equipment for almost all the maternities in Portugal. And we also started campaigns for public awareness, and also to lobby with the stockholders, and especially the National Health Service responsibles. But we were not very lucky in that last task. So, what is the national situation by now? Now we have guidelines that were incorporated in the implant cochlear guidelines. So it was an opportunity when we regulated the access to cochlear implant in children. We could incorporate some guidelines concerning the screening. And since 2015, there are guidelines. Prior to them, only local committees were responsible, hospital-based committees were responsible for the implementation and organization. What I think it's not such a good idea, because the results are very variable. So quality assurance programs of the hearing screening theoretically are imposed by the National Health Organization, but in practice they never happen, so the results were never audited. At the current time, we have only a small amount of data, and their quality is very variable. annual reports are not yet available. What are we doing? Since the beginning, we had to separate screening programs, one for Well Baby Clinic and the other one for NICU kids. And this is not, that was not very hard to implement because we traditionally had the high-risk baby screening program. And we use the 1-3-6 rule, 1 for screening, 3 for diagnosis, and 6 for intervention. I can share now with you the results of an informal survey that was conducted regarding, last year we conducted this survey regarding the 2019 births. So a questionnaire was emailed to almost all ENT head of departments concerning their results. And this is one of our first difficulties, because sometimes we are not sure who is the responsible at each hospital. So perhaps because it's easier for us to contact the ENT head of departments, and sometimes they gather information with the neonatologist or the audiologist. It was a voluntary survey, and we realized, we could confirm that most of hospitals don't have electronic data. Some of them don't have any data at all. They just perform the screening, the first, second, and hopefully the third diagnostic stage, but they don't collect the data, and they are not aware of the outcomes of the screening. So, although we know that the coverage of the screening must be near 100% of newborns, we cannot prove it. There is no evidence that the screening is universal. So, in 2019, we had almost 87,000 births. And we could retrieve information on 75–6% of the newborns. Some of the answers had not a minimum quality to be incorporated in this survey. So we know that most kids are screened at least once. We had a coverage rate of almost 97% of those kids that were included in the survey. Second stage coverage is also acceptable. We see that the referral rate is 9%, and this is because most of the screening programs are OEA based. Almost all of them. So I think it's a regular reference rate, and 69% of the kids were submitted to the second stage. So we lost some of them between the referral and the second stage. The diagnosis coverage rate was about 2.1%. So we lost some of the kids also from the identification through the diagnosis. But 2.1% of this population was submitted to effective diagnosis. And we could identify in this population 146 kids with any kind of hearing loss. It can be unilateral, bilateral, low, moderate, severe, or profound, because that kind of accuracy could not be reached by the answers at our inventory. And also, we discovered that some of the kids, 4% of the whole population, had any risk factor. We cannot be sure of what kind of risk factor it is. Some of the hospitals gave us detailed information about the risk factor they found, but it cannot be used because the great majority of the hospitals don't have records on that. So, 16 years after working in this implementation, last month a working group was appointed finally by the National Health Authority. So hopefully the next 6 months we will try to reach some of the objectives of the working group. The main objective would be monitoring all the programs and gathering all the data so we can have an idea of the quality, and we'll try to equalize the quality of the programs throughout the country. We are also very interested in knowing the outcomes. How does the screening improve quality of life of children who are born with some kind of hearing disability? And another very important objective of this group is the implementation of what we are calling the preschool screening, because this is not done actually. We have some few experimental examples, and we are very keen to use the manual and the recommendations to implement de novo this kind of screening. Implementing the preschool screening will oblige us to form a network for referencing the identified kids in preschool age. So this will be one of our tasks. The other one would be applying for funding for the equipments for the GPs, the primary care physicians and nurses, to being able to screen preschool kids. In conclusion, although universal newborn hearing screening is implementing throughout the country, due to the initiatives of health professionals, and this is our experience, is a bottom-top experience. It lacks central monitoring and quality control. And we are hoping that this newly appointed working group would be able to implement and to correct everything that needs to be fixed in the screening program. And we think that the manual that this group were able to collect will be very, very helpful for us. Thank you for having me.
Thank you very much. It was very interesting to see that your figures were very much similar to the figures I presented from the average from the eScreen.
Well, I'm not so happy because I think there is a bias, because only the people who had a minimum of organization respond to the questionnaire. So there is 25% of screeners and programs that we could not evaluate.
But now when you have the national health authorities behind you, this may improve. Do you think so?
Yes, I'm very, very expectant.
So what do you think is the key factor behind to get the monitoring and reporting done?
Well, I think the key factor would be to appoint someone responsible, an administrator for the whole country, and to being able to have a electronic platform, and that everyone can, in a timely manner, report their results. So we can monitor and we can act when something seems not to be right, in a timely manner.
Yeah. Are there any other questions from the auditor? Yes?
Thank you for this nice presentation.
Thank you.
Many things are similar from Flanders and population, number of children you screen. Maybe I was a little confused, but I would like to ask, if you look at the general population you
Yes.
have screened, how many percentage of them don't have any risk factor? Babies who
Well,
so that's sometimes
Well,
a
most of
question
them
we're
don't
struggling
have, because only, I don't remember the numbers, but only in about 2% of the cases, one risk factor has been identified. I can tell you that there are some hospitals that keep very good quality data, especially in the NICU population, premature babies, and what we see is that most of them don't have just one risk factor, they have several risk factors. And so that is a huge, a very important group, because we know that almost 50% of the hearing loss kids will come from that group. So this is a very important group for us, and we'll try to analyze it further.
Okay. We are behind in time, actually.
Yeah, very good to see the involvements and the hard work you did to have these numbers. If you have but it seemed that protocols are quite similar then, but they all have 2 steps.
Yeah.
So
Yeah.
is that regulated from above, or has
Well,
everyone chosen?
it's a recommendation, and because OER equipment is cheaper and is more easily operated, we implemented OER-based screening, but a few hospitals have the opportunity to proceed with the automated ABR whenever they find a referral baby in any of the stage, first or second stage. But mostly it's a 3-stage based protocol.
Okay, so, but it's on local initiatives, it may change, yeah, okay.
Okay, we also have 2 questions from the chat here. So there is Maria Pinto. And don't you think that it is very important to have audiologists in the NHS in the programs all over the country? In ACES, what does it mean?
Well, we have audiologists working with us. Most programs, screeners are audiologists nowadays. So they are very involved in the screening process.
So that's the answer to the next question, because she says, why aren't the Portuguese audiologists mentioned in this work? So
well, but they are.
They are?
Yes, they are always present. They were present in the steering group that is still working. And in this working group, there is also an audiologist who is currently the head of the Portuguese Audiological Society. So audiologists are very well represented in every part of the process.
So what does ARS mean? Stands for ARS. Capital letters, AR. Why not in the ARS? I don't know what AR is.
Yeah, I cannot understand the question. I'm sorry.
No?
I don't understand the question.
Shall we ask her? Yeah. What is ARS? I think otherwise we have to move on. not.
I'm sorry. Well, what I can tell you is that nowadays we have a very good number of audiologists, and every screening or diagnosis step is performed by audiologists. Usually nurses don't do it anymore. In the first times, yes, but not nowadays. And they are, of course, involved in the process of diagnosis, rehabilitation, cochlear implant fitting. So they are always working in the group.
Thank you very much.
Thank you.
So then we move on to the next speaker, who is Lisa Rubin from Israel, and she's also talking about the neonatal childhood hearing screening program in Israel.
For my PCR test.
Good morning. I want to thank the EU Screen staff for the opportunity to speak and for the many wonderful colleagues that have presented their works. I'm going to tell you a little bit about the challenges that we faced in the neonatal hearing screening program in Israel. Perfection is the enemy of the good, that one needs to compromise all the time. So our national neonatal hearing screening program started in 2010, but in more than 10 years previously, there were, as in Portugal, hospitals that had voluntarily initiated on their own fundings or with donations hearing screening programs. Most of those were OAE only, two-step. And the way that we were able to get the funding, we needed to do it nationally. Israel has national health insurance since 1995, though it was highly insured even before then. To earmark 42 new Israeli shekel, which is nowadays it's about 12 euro per screen for the infants from the monies that are paid to the hospitals where the babies are born. When we started the program, we needed to take into account that there were hospitals, and one of the health funds in the hospitals that they run were already running programs, and that they did not look kindly upon changing not their protocols but their equipment, because they had data and studies going on. And so we needed to, although we would have chosen perhaps buying equipment nationally, it would have been cheaper, and we would have chosen the equipment that we wanted. We knew that in doing that, we would generate enemies rather than partners. And so we just compromised with that. We also didn't use stated cutoffs. I know that's kind of strange, but that was part of the accommodation. Everybody was using 35 to 40 dBs. But we stated in the protocol what was considered a fail, whether it was a one-sided fail, two-sided, unilateral or bilateral fail, what was supposed to be referred. And in addition to that, we said how many times you could do the OAE and ABRs rather than, so it was a two-step OAE, you could only do it 2 times. And the ABR was to follow and only done 1 time. And the other part is that all infants in Israel, with the exception of one of the hospitals where the most births take place, the child stays the mother and the child stay in the hospital for 48 hours. That's to actually accommodate neonatal metabolic screening. But we took advantage of that. Somebody else did that hard work. And in the other hospital in the south, the children there's special dispensation for them to be discharged at 36, which means that for some of the children, you have to accommodate 3 tests within a very short amount of time when there are lots of other things that are happening. The protocol or the directive that we sent out also required reporting. But at the time, it was aggregate reporting, and we'll talk a lot about that. One can look at it, I worked in this as a pediatrician, preventative health care, and the regulator. But really what we want to make sure is that every child is screened, and every child that's screened is follow-up diagnosed, and that's ensuring seamless care. And that is not so easy, at least in Israel, because there are different care providers. We have 4 health funds. Hospitals are separate from the health funds, except under some occasions, and it has nothing to do with where you're born. They're different record systems, and they're the privacy laws. So as soon as we instituted our healthcare, our program, we tried to add hearing loss as a reportable condition, because congenital malformations are reportable, and then we would have a tool by which we could then get information legally and move it on. Well, that was in 2009 when we started working on it. It's 2021. Guess what? It's still happening. Providers, who's responsible for what and who pays? Births are not covered by national health insurance. This is another little anomaly in Israel. It's covered by the National Social Security Institute. Curative care, ambulatory and hospital covered by the health funds, and preventative care, screening programs, the government. They're all different record sources and different funding. So not so easy. And when we want to report, the baby's born in the hospital. It's covered by national insurance, national health insurance, but the Social Security. The hospital doesn't know which health fund the baby is being discharged to, because it's not done in the hospital. The baby's not born yet. So about 2 or 3 years ago, we've been working on the birth record file and trying to transfer it, to push it to the health funds, because they wanted it, understandably. They wanted to know how many preterm babies. They're not so interested, they weren't so interested originally in the results of this screen. And we have figured out a way, and the health funds are distributed a list of all the babies that are purportedly in there with about 90% accuracy, and they return reports of babies that, for reason or other, and they usually do it by allocating it to the mother's health fund, because usually the mother registers them in the health fund. But this simple step is not to be understood just generally. So that's problem number 1. The diagnostic testing after you've passed or failed your hearing screen is done as responsibility of the health fund. It's not the responsibility of the hospital. It's not covered by it. That's a whole different system. How do we merge those? And how do we get the information that that's been followed up, that's linked? So that's kind of problematic, and the testing is most frequently done in the hospital. But then how do you get that back to the health fund? One of the health funds has, they've now developed their own system of doing the diagnostic testing within the health fund itself, and they said, wow, we want the results of the screen. And I said, we've been working on this a long time. Good, you'll be the pilot, right? And then we have habilitation. That's done in a totally different, and it's not even in the health system, right? Some of it's the health system, but there's also the welfare ministry, the education ministry, and of course, Social Security. But all these problems, they also generate opportunities for getting information from different sources. So even when it's so difficult, the National Insurance Institute pays a stipend for disabilities, to children with disabilities. And they have some of the best data, okay, because they're paying money, and so they really followed the money. And they have good information. It's not very easily available, but we were able to bootstrap for Evelina and the model information about how many children were diagnosed, were getting their disability stipend by 1 year, 2 years. It's reported that way. And it's a possibility of getting that information in the future as well. So we have Band-Aid solutions, what I call them, for getting the data. One is what I said was mandated by the directive, and that's aggregate reporting by the hospitals. They get a little piece of paper, sent digitally, of course. We do it only digitally. And the hospitals and the person who's responsible for the screening, usually the audiologist, always the audiologist, excuse me, they have given a form in which they're asked how many babies were discharged from the hospital, how many were administered OAEs, how many did a full protocol, and how many, and divided up by low risk and high risk. Because it's aggregate reporting, and we've built into the form ways of checking to see whether the data is accurate. It's mostly accurate, but it's not easy. And it's very hard for the hospitals because they all have different methods of calculating their data. It's aggregate, so it's no solution to seamless care. It doesn't provide any information to the health funds and tell them who needs to be followed up. And as I said, the reliability is somewhat problematic. We've done chart surveys of rehabilitation centers for looking at the age of diagnosis and rehabilitation, and we know we did it before and after. We did it before and after, and we're in the process now of doing a rerun of that survey to see where we stand now, 10 years after the initiation of the national program. And we know that the program has made a difference. It reduced significantly the age of diagnosis. It reduced even more significantly the age in which children were entering rehabilitation. We know it by Arabs versus Jews, which is minority versus majority population, but it's not real-time monitoring. We need to know that in real time. And it doesn't solve the problem of non-testing. And the National Helsinki Committee, because this is something that's done in all rehabilitation centers, that said that we've approved it to you this time. You're never getting an approval again because you're not allowed to look at those health charts. You need to do it in the new system, which I will tell you about shortly, except that the rehabilitation system, the rehabilitation centers are not linked to the new system, okay? And then we've done follow-up surveys of parents of infants with failed screens. We know with about 95% accuracy that the children coming into the well child care, they report on the results, and we can actually have their discharge summaries. So we can base it on the discharge summaries and not just parental report. And we know that we have 80% follow-up of failed tests. Again, it's not real-time monitoring. It was to see where we were standing. Doesn't solve the problem of non-testing. Again, it's periodic and non-routine. High tech, excuse me, that's what we think is going to be the answer. When we reissued the directive in 2018 regarding the healthcare screen, we sent to the hospitals, I'm going to go down to the bottom first. We sent to the hospitals a requirement to report the baby's test results as a code. We invented codes. We took the ICD and there's a committee, a national committee that does the codes, and we said, you tell us those are the codes, you put it down there, and then because every child is discharged with and it's all records, all medical records in Israel are digital at this point. We wanted to turn the results of the code into a data byte. And as of 2019, 75% of the hospital, or 75% of the babies, not of the hospitals, were already reported as a code. It's not ready yet, but we will be able to, again, because now we can take the birth record and we can transfer it to the health funds. The health funds will know. The health funds are not looking to be examined on it, but we'll work on it, and that will eventually happen. So that permits that to be transferred in real time to the health funds. And permits them to follow up the failed screens. And it'll permit a more accurate assessment of those aggregative, it's a line-based, infant-based, single infant, in order to know about the hospital. So we're moving to that. The other part of it is that Israel is committed, has a national plan for doing data sharing between the different health funds and the hospitals. And it's now, or it's the second iteration, it's called ATON, which means strength. And it links hospitals, health funds, well, baby clinics at this point also. It's a read-only. It has to satisfy the confidentiality and all the confidentiality rules. So if you come into the hospital, the physician in the hospital can access your clinic records as a virtual record. He can't copy it. He can't write onto it. He can't transfer it. It dissipates after a certain amount of time, but it's available. And the hospital records are, as a record, the summary is actually transferred to each of the attending physicians or the caring physicians. And they, you don't have to read it, but now the health funds actually monitor how many of those records are opened up and looked at. Well, looked at, I don't think but they can see whether you've opened it up, and they actually turn that into a quality indicator. So we have ways of transferring the information now that we didn't have 10 years ago. And we're working now in order to make that something. They're not perfect because some of the hospitals will be, even though they're supposed to do all the tests in 48 hours, will, for children that they haven't succeeded, will bring them back. They're required to bring them back on their own penny. They're not allowed to charge for it to finish the screening. But that won't go into the hospital record, the discharge summary. So there are still lots of clinks and kinks that we need to do in order to fix it. But we are moving closer to having actual real follow-up data. So we're not there. Coding doesn't specify risk or need, and we need to develop algorithms to designate the infant's risk status. Is the coding done real time? Another question. But there are other links. We can have a potential link to the hospital-based data on implants. We've looked at that separately and looked at when the implants are done, and we know that there's been a decrease in the age in which the implants are actually, cochlear implants are done. And as I said, we don't have a link yet to the provision of hearing aids and social and educational habilitation. And I said that it's not reportable. And the health funds are, as I said, not rushing to take responsibility. We need to work on that, but it'll happen. So 11 years later, the National Neonatal Hearing Screening is really considered a success in Israel. It's highly regarded. I didn't give you the data because I've presented that before. And we've decreased the age of diagnosis and age of entry to habilitation. It's increased equality. It's lessened differences. But we still need a sustainable reporting system for monitoring performance. And so I want to say that there has to be some sort of balance between what we demand at the onset and making sure that we have a plan for going forward to having better reporting in order to improve the program. Because otherwise we would be, if we had waited, we would still be waiting. Thank you very much.
So the discussion will be postponed.
About vision screening in Hungary. Welcome.
Sárföző from Hungary. And thank you for the opportunity and to organize this meeting. And please allow me to...
Please speak a bit loud.
Okay, sorry. Please allow me to introduce our health system shortly. Our system is chronically underfunded. The Hungarian population is a bit under 10 million, less than 10 million. Mostly we are living in cities. The health expenditure is under the EU average, and 1/3 of it comes from out-of-pocket payments. It means that this is one of the highest in the EU and twice of the OECD average. There are huge differences between cities and rural areas. The uneven distribution and shortage of health professionals undermine access to health services in Hungary. The life expectancy at birth is below the EU average. It's shorter, it's 5 years shorter. So this is the background, and let's talk about the vision screening. It is financed in Hungary by the state, the Health Insurance Fund Management, and carried out by health visitors. We have more than 5,000 health visitors in Hungary. They have the degree of Bachelor of Science. They are well skilled, but these screenings are really quite frequent. They visit the families and do other screenings. So the visual screening embedded in a general screening program. After the newborn goes home in the first 3 days, they are already visited, and they help in breastfeeding, give advices. They document all the percentages, the development of the child, and in every visit there is some ocular function screening. In the beginning they check the eye movements, they do cover tests, the pupillary reflexes, and the pursuit movements, and then later on, after the age of 3, they do the uncorrected visual acuity test. They check the color deficiencies, and they use the Lang 1 stereo test to detect the stereo acuity. They are not orthoptists. We have no such a program in Hungary, unfortunately, but all screened children who has a positive result are sent to a pediatric ophthalmologist. I think we have a quite large referral rate and a high false positive, but all of the children, almost all of them are screened, nearly 99%. This is an outstanding rate globally. But I agree that we have a very frequent screening. And from year to year, if there is even a negative result, the next time there will be the same procedure. So it doesn't matter whether it's positive or negative. If the child doesn't take part in the screening, then the health visitor reports it to the child welfare service. The visitors are under the supervision of the GPs. They work together, but not in the same room, just in the same building. In Hungary, there aren't uniformized acuity tests. The protocol of the test was lastly reviewed in 10 years ago, so it's not that new now. We should renew it. Maybe it's this model, the screen model, will be a great opportunity to do that. This is one of our mostly common use tests. This is done by Anna Soproni. This has a logarithmic scale, but these signs are not monomorph. We haven't got a crowding effect. This is for non-verbal children mainly, and each part is a very cute face cover shield. But we have also other tests just for the pre-verbal, partly for pre-verbal children, and the screening is in the age of 3 and in the age of 4, in the age of 5 and 6, and after it in the school age, and every 2 years there is a screening for the visual acuity. The equipment differs and depends upon the financial income of the given region. There is no photo screening at this level. So in Hungary, we have a quite well-organized screening. The children are well covered. And now we have a cloud-based database. And I think maybe this can help us to do statistics. We have no data about the efficacy of the system. We don't know the sensitivity and the specificity of the screenings. But all of the data, either private or public hospitals, and even from the pharmacies, are sending now, in the last year, from the last year to the general database, and it can be seen by any of the other doctors and health professionals, and maybe it will help to avoid repeating duplicate examinations and treatments, prescriptions. The coding is a question, but if it will be correct, then it can help us to evaluate the screening. The disadvantage is that there are huge problems in the rural areas, lack of pediatric ophthalmologists. We would need more photoscreening devices, and we have no orthoptists. There is no program for their training in Hungary, so there is a missing step between the health visitors and the pediatric ophthalmologist. They have a very low salary, but I hope that it will change in the future. Thank you for your attention.
Thank you. I have one question from Anna Horwood. She wonders if the vision screening takes place at the same time as other health checks, because that would be cost saving, or is it separate visits?
There are no separate visits because this is so organized. Sometimes it's in the same time as the vaccination.
Okay.
So they go to the vaccination, and there is a several page sheet paper and the health visitor describes all the data, and this is so in Hungary. It's common.
Thank you. So thank you very much. And then Herb has a question.
If we compare the situation in Hungary with our recommendations for Romania, several parallels can be drawn. For instance, you also have the difficulty in the rural areas of reaching all the children. Then, secondly, you screen at many other ages apart from 4 and 5. And in Romania, we recommend to concentrate on 4 and 5 because it's by far the most effective. Is that not something that you could also adopt?
Yes, we have to lessen the screening periods. It's too frequent now.
Yeah. Okay.
Thank you for the advice. It won't be difficult. It will be difficult. We have to contact with the Society of Pediatric Ophthalmologists and with the health ministers, and we will see, because this system goes back to 1915. It's a very old system, and there is a huge number of health visitors, so it has renewed somehow, because this is the new model shows that it's not cost effective. And
you also need orthoptists.
it would be a great help for us because we do everything. We have no orthoptists from the beginning to the end, and these visitors, they just check the uncorrected visual acuity, and it's not enough. So it.
And how many orthoptists are there in Hungary?
We haven't.
Zero.
So
you start a school of orthoptists in Budapest.
It would be nice to have one.
Yes, would be good.
Thank you, Rilla. Sorry to say the wrong name. Rilla, what's your name? Thank you. And from a place with good organization, we will move to some place with maybe not as good organization. So we welcome Like Guma to talk about the vision screening in Rwanda.
Yeah. So welcome. Amato and Amatkui, the eyes and ears in Rwanda. Let me see how I'm gonna. Yeah, my name is Lieke Gauma. I work at the Rwanda charity eye hospital in Rwanda, but I also work in the Netherlands at the Rotterdam Eye Hospital. This is one of my patients the day after surgery. Later on, you'll see a photo of her the day after surgery. I'm going to tell you a little bit about Rwanda today, the healthcare in Rwanda, very little bit about the hearing part. Then we'll go to the seeing and the future. So Rwanda is a country, Central Africa, just below the equator. It's about 3/4 the size of the Netherlands. And the neighbors with Uganda, Tanzania, Burundi, and Congo. So you kind of know where it is. Yeah. They have 12.7 million inhabitants, and compared to the Netherlands, they're slightly more dense populated. But as you can see, Rwanda is really green. It's also called the country of 1,000 hills. And many people live on the countryside and are farmers. More than 50% lives below the poverty line, and at least 30% women per public body, and most women in the government in the whole world. So I think that's a good thing. Rwanda is mostly known for the genocide from 1994, where almost 1 million people were killed in 3 months' time. It was a war between the Hutus and the Tutsis, but those words are not allowed to be said anymore in Rwanda. You can't ask somebody if they were a Hutu or Tutsi. They say, no, we are Rwandan, we are one nation, we're looking to the future. And Rwanda is really a country looking to the future. It's a really clean country, there's no garbage in the street, and it's safe. I think it's even safer than some cities here in the Netherlands. I can walk around in the street on my own, which is something in Uganda, it's even more difficult. So healthcare in Rwanda. Almost everybody has an insurance, and it is based on your income, what kind of insurance you have. So there's one from the government, it's called the Mutuelle de Santé, and if you earn, well, if you're poor enough, you can get that insurance. And it's about 8 or 9 euros a year, and if you have that insurance, it covers 90% of your consultation, examination, medication. So you have to pay 10%, which means for consultation, you have to pay around 200 Rwandan francs, which is about 20 euro cents. So, but the general income is €1 a day, so for some people it's still pretty much. And if you earn more money, then you have to get a private insurance. So you have to pay, according to your insurance, you pay for your consultation. Almost everybody has the insurance, because if you have to go to a clinic and you don't have any insurance, you're considered as a private patient, and then you have to pay 100% of all the costs. So Rwanda has health center and district hospitals. We'll go into that part later. There are 3 eye hospitals, which is even more than we have here in the Netherlands, actually. There's still schools for the blind. There's 1 school for the deaf, and there's some audiologist nurses. But let's go to that part. First question, is there screening? No, there's no hearing screening. There are some audiologist nurses. I just found out last week that the Starkey Hearing Foundation trained some audiologist nurses in 2019, but I found last week. So I haven't had the chance yet to ask them how many people they trained. They can do some diagnostics. That's it. There's no screening program. And there's 1 school for the deaf, but it's all the way in the north of the country, and it's pretty expensive for most Rwandans to pay the school fees. Yeah, if we go to the seeing part, which I know a lot more about because I work at some eye hospitals there. Is there screening? No, there is no screening. First, I was a little bit confused why Rwanda is in this whole study, because like I said, there's no screening, but yeah, we can have screening maybe. So like I said, there are 3 eye hospitals, and let's compare to the Netherlands again, because we are here in the Netherlands. Netherlands has around 650 ophthalmologists, which is 1 ophthalmologist for every 26,000 people. If we go to Rwanda with 12.7 million inhabitants, where there are 20 ophthalmologists, there's just for consultation 1 for every 635,000 people. If you want to get surgery, there's only 7 ophthalmologists doing surgery. Not all of them are really good. Yeah, so that's a little bit difficult. This pyramid, it's really small, but I'm going to tell you what it is. It is made by the WHO together with the government of Rwanda. So there are around 45,000 health workers around the country in around 14,000 villages. And maybe some of you know the organization Vision for a Nation, they trained in 2017, I think, around almost 3,000 of those health workers to do eye screening. They don't do it, but they got a training. Then we have around 500 health centers, which is like a very basic clinic. You can get really basic care, but there are no really eye-related working people there. So if you have a problem, you have to go to a district hospital, where only 34 in the whole country, and we have ophthalmic clinical officer working there. An ophthalmic clinical officer is like, no, well, not really an optometrist, it's half an optometrist. And they have some eye drops, and they have some materials to do some eye checks, and can treat like basic eye care. But if they still can't help you, they have to send you to a referral hospital where are some ophthalmologists working. And if you're lucky and you need surgery and there is a doctor there who can do surgery, you're in a good place, and otherwise you have to be sent to an eye hospital. So imagine you're on the countryside, and I heard the most crazy story one time. There was a chicken who had their nails like scratched the eye. So you go to the clinic, you go to a district hospital, then you go to a referral hospital, and then you end up at the eye hospital. Some days later, the eye had to be taken out. So the equipment is really different of all these places. And for example, the autorefractor is something which needs to be checked every once in a while if it's still functioning, but nobody knows how to do it. So also the equipment, it's not always the best quality. If we go to the staff, for example, retinoscopy, for the hearing people among us, retinoscopy is something how you check the eyes, for example, for children, how to measure what kind of glasses they need. There's only one ophthalmologist in the country who knows how to do it. It's a Belgian ophthalmologist, Dr. Piet Noé. And when I'm there, I know how to do it, and nobody else knows how to do it. So you can use on the machine to do it, but like I said, nobody ever checks if the machine is still working right, so it's a little bit difficult. When I was there, one of my first times in Rwanda, I was working in an eye hospital, and every time I saw the file, it said VA child, and VA is visual acuity, so how much somebody can see, and it said child. So I said, why does it say child? Yeah, we don't know how to examine a child. I said, why? They know the E chart, you can do numbers. No, we don't know. I said, you know what, send me all the children, I don't care what they're complaining about, let me just check. So 2 brothers came in, and they were 5 and 7 years old, and they were already in the hospital for 3 years as a patient, complaining of scratching, itching, redness, which most people complain about, and it's an inflammation of the eye. And every time in their file, it said VA child. So I said, and it was a pretty rich family, they spoke English, which was lucky for me. And I said to the dad, let me check how much they can see. No, the father said, we just need the drops. I said, well, you're here, let me just check. So the only thing the boys could see was when I was standing 1 meter from them, 2 meters, holding up my fingers and asking them how many fingers I was holding up. So I said, let me check. The boy who was 5 had -7. The boy who was 7 had -9. I'm -9. If I take off my glasses, here my hand is already blurry. So I said, how is school? Yeah, they're not doing so well in school. Luckily, I took the trial frame, put the lens in, put it on the face of the boy, and he was like this. And then I thought, this is the first time he can see. And these boys were already in hospital for 3 years, but nobody ever checked them. And luckily, the hospital had an optical shop, so about an hour later, they came back with their glasses showing, and so proudly and happy and pointing at things, look, and they could see. And then I thought, this is why I'm here, because those boys never got checked otherwise. And the Belgian ophthalmologist is the sweetest, most gentle man I know. And the next morning at the staff meeting, I never go there, it's in French, my French is not that good. He was so angry that nobody ever checked those boys. And after, the whole staff came to me, please, how do we examine children? So I was teaching them. And I said, if I ever come back to this hospital, which I did, I never want to see VA child in the file again. And luckily, every time I came back, there was no VA child in the file anymore. And that's why also when I try to go to Rwanda every year, I also teach at the university about how to examine a child. For example, if you examine them, for adults you can ask them, cover your one eye. But if you do it for children, they will do like this. So it's basic things like that. The next slide, School for the Blind. There are 2 schools for the blind. One is run by Polish nuns. Some children are in the school for the blind, but are not blind, they just need glasses. But there's no screening, so nobody checked. Next slide has a disturbing photo. If you don't like to see something not very nice, here's your warning. The one left on the down is a boy who came in like this. This is the problem in Rwanda. They come in very late. This boy died a few days after this photo was taken because of the tumor. This one on top here is a boy. This is one day after his cataract surgery, and this was the first time seeing light. So we can still, this is actually the ophthalmologist, so we can still change lives with surgery, glasses. But yeah, this one is born without eyes, actually. You see some children with albinism, of course, like everywhere in the world. These are photos from the School for the Blind. The right photo down on the right, I made at an orphanage. I was screening at an orphanage, and there were 2 brothers with albinism. Nobody ever checked their eyes, and they now have glasses, so that's good. For 17 days, this is a few years ago, I just made a list about what patients my patients were complaining about. And almost half were complaining about an inflammation of the eye, itching, scratching, redness, tearing. That's what they come in for. And only this little bit, 16 out of 365 come because of blurry vision. Because if you see blurry your whole life, like these 2 brothers, you don't know that you can see clearly, because you think, oh, the way I see is how everybody sees. So they come in very late, like with a big tumor. They come in when they had a knife in their eye, and they come in 2 weeks later because they have saved money for transport, for consultation. You see a big group here came complaining of strabismus. That is biased, because when I go to Rwanda, they announce on the radio, oh, somebody is coming, and if your eyes are not straight, come to the eye hospital. That's why there's a big group. But normally, there are not that many strabismus. This is actually the girl from the first photo. So now she's straight. So if we look to the future, can Rwanda has screening? Well, let's first answer some other question. Herb sent me some questions about this, actually. Can you use schools? Well, in the capital or in the big cities, most children are in school, but they're only in school when the parents can pay for the school fees. Especially in the countryside, when the people, like I said, earn around €1 a day, children have to help fetch water, watch the goats, cut the grass, whatever. So most of the time they're not in school unless they're enrolled in an organization like Compassion, who's doing a lot of work there. So you can get quite a good amount. Most children in Rwanda do get vaccinated. When they're born, they immediately are scheduled for their vaccination, but that's only for the first year. You can do some basic eye screening in that first year. Who can do screening? There's no orthoptist in the country, there's no optometrist, so the only people we have, like I said, are the ophthalmic clinical officers. They have optometrist kind of people who can screen, but like I said, don't really know how to screen the children. And you only have around 50 in the whole country. How are you going to screen them when there is very limited materials? Where are you going to send them to if they do need a referral? Are you going to send them to the eye hospital? Okay, good, but who's going to examine them at the eye hospital? Is it the only 20 ophthalmologists we have in the whole country? And how are they going there? If people have to pay, for example, if they're deep in the countryside, public transport for us, it's cheap. If you go on a bus for 2.5 hours, it's about €2. But if you have to pay €2 for yourself, €2 for your child, you have to pay for your consultation. Most of the time you arrive at the hospital, you have to wait the whole day. Then you end up, you have to sleep there, which is arranged at the hospitals, but you have to pay to sleep, to eat. Next day you have to travel back. So who's going to pay for all that? I don't know if people are really willing to pay for that. This is pretty bad, but if a white person says you have to go there, they will go. but he also always worrying about money. Who can prescribe glasses? Like I said, not many people know retinoscopy. Where are they going to buy the glasses? Who's going to pay for the glasses? So there's still many questions to be answered. So can we do eye screening? I think so, but not very soon. Thank you very much, Morikosi Chane.
Thank you very much. Is there some urgent question? Yes, one question from Lisa.
Thank you for that most interesting talk and also wonderful work. In the manual, if I remember correctly, one of the first things it says is that you have to consider what are the things, what are the other concerns in the country. And if one would institute, I would think that if one would institute screening in a place like Rwanda, one would have to think very seriously about what one wanted to screen for. And the first thing, I mean, a question or a comment is, you know, trying to prevent the causes of severe blindness, and identifying cataract and visual. Those are things that can be done under the, perhaps not by,
I think so.
not by professional eye caretakers, but the people who are doing the immunizations and can do that for the newborn babies and then find a way to refer them, and having some sort of think tank about thinking what one wants to screen for before one goes on for what are more luxury items, I would say.
No, true. Yeah.
Lieke, this is of course fantastic work, huh? But in some way it should be incorporated in the preventive healthcare. What do you see any solution? How can the refraction be carried out in Rwanda? Or should we first listen to the next talk about the system they are now adopting in India? Would that be a good idea? Then we come back to this question. Okay.
Greetings. I have an elaborate title. National Vision Screening in India aims at refractive errors at age 9 to 14 years. How much amblyopia would be detected by screening at an earlier age? I thank my co-authors, Eveline and Sarah, for their contributions and support. None of us has any commercial disclosures to make or any conflicts of interest. My heartfelt thanks go to Professor Simons and the UScreen team for their unwavering commitment and support towards providing a meaningful and useful direction of the UScreen cost effectivity model with respect to India. Thank you so much. India is a diverse country of 28 states and 8 union territories with a total area of 3,287 million kilometers square and a population of approximately 1.3 billion as per the 2021 census. The birth rate is 18.2 per thousand population. The death rate is 7.3 per thousand population. The growth rate is approximately 1.1%. All this is 2020 data. 25 to 26% of the population is under 14 years of age. 26.6% of 1.3 billion people is approximately 363 million children in the 0 to 14 year age group. This comes to about 26 million children per birth year. When we extrapolate this data to the approximate population of children in the 9 to 14 years age group, we are talking of approximately 130 million children. Before I proceed further, I would like to appraise the audience of the national programs related to vision in India. In 1956, the first such program was the National Trachoma Program, which was 100% centrally funded. Trachoma was one of the most common causes of blindness then. In 1976, the scope of this program was expanded to incorporate other common causes of preventable and curable blindness like cataract, glaucoma, corneal blindness, retinal blindness, nutritional blindness, etc. And the program nomenclature was changed to National Program for Control of Blindness, or in short, NPCB. In 2001, the NPCB adopted the World Health Organization policy of right to sight, or Vision 2020, and the aim was to decrease the prevalence of blindness in India from 1% at that point of time to 0.3% by 2020. This is the first time that the focus was on childhood blindness and refractive errors in a national policy. Thus, the national priorities have been changing depending upon the prevalence of any particular cause of preventable or curable blindness in the country from time to time. Till 2014, this program was completely funded by the center. However, after 2014, the funding was now divided between the center and the states in a ratio of 60:40 and 80:20 in difficult terrains. Also, the nomenclature was again modified to include visual impairment. Till now, the program had focused only on blindness. Now it also incorporated visual impairment as a goal, and the program was called NPCB-VI, incorporating visual impairment as VI. Initiation of the vision screening program in school children with respect to refractive errors was a part of this policy, which was to have rolled out in 2020. I would also like to provide an overview of the vision healthcare delivery system in India under the NPCB-VI. There is an Apex Center at the Dr. R.P. Center for Ophthalmic Sciences at the All India Institute of Medical Sciences, New Delhi, India. Then there are 18 regional institutes of ophthalmology, which are upgraded ophthalmic institutions of excellence associated with teaching institutions. These have a huge catchment area to provide primary and referral services. In addition to this, in parallel, there are 541 medical colleges with their own departments of ophthalmology, 734 district hospitals with an eye department, and a plethora of private hospitals and institutions, some of which you may be familiar with, like the Shankar Nethralaya or the Arvind Group or the LV Prasad Group of hospitals. The community outreach programs of these private institutions are substantially funded by the NPCB-VI. Coming to the rural network, one village in India comprises a population of 1,000 people. 5 such villages, that is approximately 5,000 people, are catered to by a medical sub-center, which at present does not provide ophthalmic services. 6 such sub-centers comprise what is called a primary health center under the aegis of one medical officer. That is, a PHC caters to about 30,000 people. There are about 24,000 PHCs in the rural network and 6,000 in the urban network currently. Since 2014, an ophthalmic assistant is being mandated at this level. 4 such PSCs comprise what is called a community health center. These are usually 20 to 30 bedded hospitals catering to a population of about 1.2 million people. This was the level at which an ophthalmic assistant and an optometrist was present. However, as I mentioned, that an ophthalmic assistant is now being mandated at the level of the PHC also. The ophthalmologist comes into the picture only at the level of the district hospital, which is also the level at which ophthalmic surgery starts. Here, I would also like to draw your kind attention to the school eye screening programs, which became a part of the NPCB since 1994. Pretty much of the design, concept and infrastructure of the National Vision Screening Program in School Children 2020 is based on this preliminary program. I would like to mention that primary education in the age group of 6 to 14 years is mandatory in India, and as per 2016 data, there are 840,000 such schools catering to primary education in India. Coming to the National Vision Screening Program 2020, the school eye screening by trained teachers has been the largest group catered to under NPCB after cataract. It was planned to prioritize this program in a more collated way under the aegis of the Vision 2020 policy to provide homogeneous screening services throughout the country. This is the policy booklet that is available free over the internet. I have copied the link also for the reference of the audience. Based on administrative, logistic, social and medical reasons, the student age group of 9 to 14 years was selected for greater reliability of results of testing, students understanding the purpose and need of the testing and who also acted as social messengers, and also to screen for myopia in the prepubertal adolescent age group. Myopia has almost been an epidemic in the East Asian countries recently. While this is not entirely true for the South Asian population, it was considered appropriate to screen for myopia in the prepubertal adolescent age group, where an increase in axial myopia is characteristically seen with the generalized adolescent growth spurt. With this background, I will now talk of the application of the U-Screen cost effectivity model for early amblyopia screening in India. Based on the Indian National Sample Survey 2014, the number of children in the 6 to 13 years age group is approximately 204 million. The total number of children out of school are about 6 million. So the total number of school children in the age group of 6 to 13 years is approximately 198 million. Averaging this out, the total number of children per birth year is therefore approximately 28 million. This data can be extrapolated to the 9 to 14 years cohort specified for the school vision screening program, that is approximately 141 million children. Now we come to the cost effectivity assumptions. If we assume that at first 20% of the targeted population of school children in one birth year, which we already mentioned was about 28 million, is screened, the total number of school children to be screened is about 5.6 million children. Of these 5.6 million children, we can reasonably assume that 10% are already under good ophthalmic care, wear glasses, etc. and don't require further screening under this program. This makes up for a population of approximately 5,040,000 children who will require screening under this program. The estimated budget for this program as in 2020 was approximately 78 million Indian rupees, which I'll be referring to as INR from now on, which is equivalent to about 886,000 euros at the current conversion rate of 1 euro to 88 INR. In direct calculations, this means that one screen test, if we divide 78 million INR by the population of 5,040,000 children to be about 15.4 INR or about 0.17 euros. There is another way to cross-check this calculation. The identified personnel to conduct the screening are school teachers with a salary of INR 29,166 per month or about 331.4 euros as per current conversion rates. At a 40-hour per week work schedule, the total working hours are thus about 168 hours per month. Assuming the screening evaluation to take about 3 minutes or 0.05 hours on an average, the manpower salary cost per screening test is about INR 29,166 divided by 168 into 0.05, that is approximately INR 8.68 or 0.1 euros per screen test. As mentioned previously, as this program has already been in effect since 1994 with an infrastructure and network support that is already present, we can assume a 50% recurring overhead cost for the actual screening to take place. This works out to be approximately 7.73 INR or 0.08 euros. Thus, one screen test would cost approximately 16.41 INR or 0.18 euros, which is similar to the more simplistic calculation shown in the previous slide. Insofar as the School Screening Eye Program 2020 in India is concerned, we can stop over here at the cost per screen test. However, applying the U-Screen model for further health interventions and management in this cohort, if we assume that 10% of the screen subjects will be sent for diagnostic evaluation of the refractive error in focus, that is myopia or amblyopia, this comprises a cohort of 504,000 children per birth year. Evaluation of these children by trained optometrists at a salary of INR 31,416 per month or 357 euros at current conversion rates, again with a working schedule of 168 hours per month and an evaluation time of about 15 minutes, that is 0.25 hours per child. The manpower salary cost per diagnostic evaluation comes out to be INR 46.75 or 0.53 euros per child. Thus, the total cost of the diagnostic evaluation for 504,000 children would be about 23.5 million INR or 267,750 euros at current conversion rates. The prevalence of amblyopia varies between 2 to 5% globally. Assuming a prevalence of 3.5% of the subjects referred for the diagnostic evaluation, that is N is equal to 504,000 children, about 17,640 children are expected to have amblyopia in this cohort. Assuming that 25% of these subjects would receive management from other sources, about 13,230 patients are expected to be treated under this program. Taking the costs for optometry services to be the same as what has been elucidated in the previous slide, accepting that the duration for amblyopia management services would be about 27 minutes for the optometrist, the cost per child comes out to be INR 84.15 or 0.95 euros as per current conversion rates. In addition, ophthalmic assistants would also play a nominal role in vision assessment in these children. Estimating a 3-minute evaluation per child, the total costs for the ophthalmic assistance services would be INR 4.29 or 0.05 euros per child. Thus, the total duration of time for amblyopia management services by the optometrist and the ophthalmic assistant would be 27 plus 3 minutes is equal to 30 minutes per child. Also, thus, the total manpower cost of providing treatment to a child with amblyopia is INR 84.15 plus INR 4.29 is equal to INR 88.44 per child. That is approximately €1 at current conversion rates. The average cost of glasses is INR 500 or 5.6 euros. Thus, the total cost of prescribing treatment in glasses per child is INR 88.44 plus INR 500, that is INR 588.44 or approximately 6.6 euros. The total cost of providing amblyopia treatment to 13,230 subjects is therefore 7.7 million INR or about 87,318 euros as per current conversion rates. Now, 75% subjects would respond to refractive adaptation or glasses only. Patching may be required in the remaining 25% cases. We have an improvisation for patching. A 2-inch micropore adhesive is cut in the shape of a patch and an appropriate paper patch of a smaller size is pasted on its adhesive side, thus simulating the look of a commercial patch. This is extremely economical as a micropore can last for months. So the costs of this is not being calculated here. We have provided additional costs for the first preliminary management protocol for amblyopia. The anticipated cost for follow-up evaluation will be less because of lesser time required by the manpower, that is the ophthalmic assistant and the optometrist, as well as the fact that the glasses need to be changed if required only after 12 months. Thus, in synopsis, we estimated that the cost of vision screening in children as per the School Eye Screening Program 2020 in one birth year is about 16 INR per child. Costs for diagnostic evaluation for myopia and amblyopia would add about 22.5 million per birth year to the costs of this screening program. Further, costs for amblyopia management would add about 7.7 million INR per birth year to the costs of this existing program. Hence, the costs for diagnostic evaluation for amblyopia and its further management in one birth year is INR 31.3 million. This can be added to the sanctioned costs of INR 78 million for visual screening, which is already present. This would be a total of about 109.3 million INR or about 1.2 million euros. This additional cost of INR 31 million per birth year for diagnosis and management of amblyopia can be added to the cost of the existing program from 9 to 14 years of age. Now, screening for amblyopia at 9 years can be a bit late in terms of further management as visual plasticity decreases with increasing age. The average compulsory age of admission to primary school in India is 5 years in 14 of 28 states and 5 of 8 union territories, and 6 years in 12 of 28 states and 3 of 8 union territories. The national compulsory age for primary school admission is, however, 6 years. If we incorporate inclusion of 20% of the number of school children at 6 years of age, which is 5.6 million children, and further deduct 10% of those who will not require screening, and apply the fact that 3.5% of this cohort is expected to have amblyopia, we are dealing with a population cohort of 176,400 amblyopic children. 75% of these children with amblyopia would respond to glasses, which makes it a cohort of 132,300 children. Extrapolating the costs of screening, diagnosis and management, including glasses per child for amblyopia, would thus be INR 16 plus 47 plus 588 as per what we have already estimated and shown in the previous slides. This would be equivalent to INR 651 or about 7.3 euros. Therefore, the total cost for screening, diagnosis and management of 132,300 children would be about 86 million INR or approximately 1 million euros in one birth year. This program can be separately started at 5 to 6 years of age as an amblyopia specific screening, diagnosis and management protocol. Thus, if we add visual screening for amblyopia with its diagnosis and management at 6 years of age to the existing School Eye Screening Program 2020, we add costs of approximately INR 86 million per year, approximately 1 million euros per year for 3 years from 6 to 9 years. In case we want to start this amblyopia screening, diagnosis and management program at 5 years, it would entail an additional cost of INR 86 million per year. After 9 years of age, an additional cost of INR 31.3 million or about 356,000 euros can be added to the existing sanctioned costs for the School Eye Screening Program 2020 for children from 9 to 14 years of age. This would indeed be an effective and extremely useful addendum to an existing school eye screening program and a meaningful application of the U-Screen cost effectivity model for early amblyopia screening, diagnosis and management to the benefit of millions of children in India. Thank you so much for a patient hearing.
Thank you, Sia Chaudhuri. Is there a question? Herb?
Zia, this is really a, what would you say, a torrent of figures. So it clearly demonstrates that people from India are very good at mathematics, but also Evelien is very good at mathematics. But to summarize it, it means that if you increase the current program that screens for myopia and other refractive errors at the age between 9 and 14, if you let that start at 6 years of age, it is, how much was it, 15% more expensive? Maybe you should chat the answer because we don't hear the sound.
Oh, okay.
Oh, now we hear you. Now, chat us the figure because we don't hear the sound.
Yes, can you hear me now, Dr.
Yes.
Simons? Okay. Now, yes, approximately it would add about 50% more to the costs. For 5 years, we have 3 years, which would be about 1 million euro each if you start at 6 years, 7 years, 8 years. And from 9 to 14 years, we are adding about, say, 0.3 million euros or something like that, so 30,000 euros. So that, let's say, about 1.5 million euros and 4.5 million euros to something that is already about 4.5 million euros.
Excellent. So you're now writing a paper about this with Evelina.
Yes, because this has really come out very well. I thank Evelina for that, but I took a long time because the calculations had to be done properly. I wanted to give an accurate representation here. So I could only send you the presentation by Sunday. I'm so sorry about that. Thank you.
So now we have coffee break. Thank you very much, Thea.
Thank you.
Bye.
Thank you so much, Dr. Shimons. Thank you.